Hello and welcome to the latest panel discussion from the Underwood Center for Digestive Health at Houston Methodist Hospital. My name is Eamonn Quigley. I serve as Chief of Gastroenterology and Hepatology and Co-Director of the Underwood Center for Digestive Health here at Houston Methodist. Today we're going to address a very important topic for everybody, namely colon cancer screening and colon cancer management. There have been a lot of new issues in this area, some controversial, some not so controversial, but the good news is that there have been a lot of developments which are going to help people with managing this common disorder. So I'm looking forward very much to hearing the opinion of my colleagues who are now going to introduce themselves.
Hi, my name is Svetang Desai. I'm a gastroenterologist and section chief at Houston Methodist in Sugar Land.
Hello, my name is Rachel Schiesser. I'm a general gastroenterologist at Houston Methodist Hospital.
My name is Monisha Singh. I'm a medical oncologist at Houston Methodist Neal Cancer Center. I'm the chief of service for our clinical side.
Great. So this is a big topic and we have a lot of things to cover. So Dr. Singh, I'd like you to start off and kind of set the stage by telling us where we are in 2025 with colon cancer in the US.
So in terms of where we are at, I think we still have to advocate for screening so that we can pick this up early. I'm sure we'll talk about screening more with our discussion, but the screening modality is sometimes a little bit challenging. As we know, screening is colonoscopy. So it'll be interesting to hear from your guys' perspective as well in terms of Cologuard and other ways of trying to supplement colonoscopy screening. And how to also try to improve the adherence to that so that we can pick these cancers up early. Because as we all know, if we can pick these up early, the more successful we are from our side to treat them. Additional topics that have come up are about how we have been seeing, and we can see this in the clinic, an increase in younger patients who are developing colon cancer. And the problem is that the screening starts at 45, but yet we're seeing 30-year-olds left and right with colon cancer. Physicians aren't really educated about that. Primary care physicians are just not pursuing, abdominal pain like perhaps they should be. And those patients, unfortunately, seem to also have a different biology. So they're presenting with pretty advanced stage and have a bit of an aggressive course compared to our older population. And then, of course, another hot topic in colon cancer is the world of immunotherapy. Unfortunately, right now, that's sort of isolated to only about 15-20% of the total population who has mismatch repair deficiency and also minority who have Lynch syndrome. So trying to sort of change that or modify things so that we can use immunotherapy in the patients who are non-MMR deficient, trying to make their tumors hot, where we can use that. That's also another interesting topic that we should talk about.
So you've actually mentioned several important points there. Recently, I looked at the literature on colon cancer worldwide, and three things stand out actually. First of all is that overall the mortality from colon cancer has actually decreased, except in the group that you mentioned,
right,
which is very scary.
Yes.
In these younger people, the mortality is actually going up. Whereas in all other age groups, mortality has gone down significantly. It's not zero,
right,
but it's gone down significantly.
Right.
The other thing which is very interesting is that colon cancer is now becoming common around the world. And there are parts of the world, such as, for example, sub-Saharan Africa, where colon cancer was never heard of, which is now, and it's now becoming one of the leading causes of death. What have we learned from the epidemiology of colon cancer around the world?
So some things we know and some things we don't know. So obviously the sort of transition or spread of the Western diet, lack of exercise, lack of fresh food, more processed foods, which unfortunately are spreading. These is not helping the situation. This is maybe why we're seeing colon cancer going up in areas where we didn't usually see that. And then, the million-dollar question is, why are we seeing this incidence in younger patients? We test all of these patients. We do germline testing on them. And frankly, personally, I don't really see them having a germline mutation. Something else is going on. There's a lot of hypotheses out there. Microplastics, we're seeing that, and they do, autopsy studies, and they see you have a teaspoon of plastic in your brain. So changes, I think, in diet, and then also sort of our our globe changing. We're poisoning the planet. We seem to be poisoning ourselves as well.
So, Dr. Schiesser, I want you to take this up now. So you're a practicing gastroenterologist. Do general gastroenterologists see a lot of patients who need colon cancer screening? What is your current practice now with regard to what age you recommend commencing colon cancer screening?
Yes, I am a big advocate of the age 45. And as Dr. Singh alluded to, if younger patients have symptoms, I don't say, okay, well, maybe this little bleeding that you saw was hemorrhoidal. I have a lower threshold for making sure that people get thoroughly checked by doing colonoscopy if they're having any symptoms.
So that's a really scary situation when you're talking about 30-year-olds developing colon cancer. And as you rightly point out, they can do very poorly.
Mm-hmm.
So apart from symptoms right now, we're not mandated or even actually would not be covered to do screening in these patients.
Right.
Overall, the numbers are still fairly small. So I think it's unlikely that we will get approval anytime soon for colon cancer screening at 35 or 40 or certainly not 30.
Mm-hmm.
So in the meantime, obviously, we've got to look at symptoms, look for anemia, various other things. How about other testing, non-invasive testing for colon cancer? Where are we with that?
So far, the non-invasive testing is still recommended for age 45 and up. And also for only patients who are at average risk. Anyone who's higher risk should go for colonoscopy because it's the most preventative test.
So where are those other tests stand now? They've got the FIT test, which is widely used. We've got the Cologuard test. We've got the old Hemocal test. So
yes.
Where would you put those in your armamentarium?
Mm-hmm. So I really try to go for a more preventative option. So if I'm going to do non-invasive testing, I will go probably for one of the FIT DNA, which would be the Cologuard, because it does have the highest sensitivity, not only for detecting colon cancers, but specifically advanced adenomas. As a gastroenterologist, part of my job is to find colon cancer, but what's really rewarding is preventing it. And the Cologuard, having a sensitivity of almost 50% for the large precancerous polyps, allows us to do a little bit more preventative than just finding cancer early.
Dr. Desai, I've heard you saying that colonoscopy is king. So tell us where we are with colonoscopy.
Yeah, so I to touch on the topic, I think first of the younger patient with clinical risk or concerns, especially as we see the increasing incidence. I think the reality is querying the patient without feeling like we have to jump to colonoscopy is really the way that I've approached it, which is, okay, it sounds hemorrhoidal to me, but I have those patients have really close follow-up so that if the standard of care treatment for hemorrhoids is not really helping or alleviating the issue, then those are the patients we say, okay, look, what I would consider as the appropriate therapy for hemorrhoids has provided you no relief whatsoever. We got to go looking. And I think the patients appreciate that, especially when I think about it. If I was in my 20s, I'm not really running to go have a colonoscopy. It's a pretty big barrier to entry just to come see a gastroenterologist when you're in your 20s. And so I think the reality is that some of that nuance comes with making sure that we're explaining to the patient, number one, that, hey, look, we're worried too, but there may be a way that we can treat this without having to run you to an exam. But I mean, I have now a cohort of patients, double digits, that we've diagnosed colon cancer earlier than 30. I mean, the youngest is now in 21, sporadic. And in that patient, we did that thing. But she came in, she said, I've been having some intermittent bleeding. It sounded, she told a story for hemorrhoidal bleeding. I was like, okay, well, we'll treat that. And she came back 30 days later. She's like, it's really no different. And we did a colonoscopy. She had stage 3 tumor. And it's good that she trusted us to come back, number one. Number two, if I had tried to get her for a colonoscopy for that first visit, she wouldn't have come for it. So I think the reality is that for us, when we think about it, as clinicians, I think it's really important that we, number one, take that good history, understand what's going on, as well as I try to read the room, so to speak, all right, is this patient freaking out and a colonoscopy is what they want, and I'm happy to provide that for them because it helps my paranoia? Or is it like, hey, actually they're not the right patient yet, or they're not tuned into the idea that an invasive procedure is necessary, so then we manage the treatment. But as Dr. Quigley said, colonoscopy is king, and I think the reality is that the colonoscopy allows us for adenoma detections rate that are still far superior to all of our non-invasive testing. And I use lots of our non-invasive testing in reality for the right cohort of patients, but we know that we do a much better job of detecting polyps than any of our non-invasive tests, at least currently. And so the hope is that those tests get better, and it looks like there's some evidence that that's improving, especially as we start to add the microbiome and the microbiome testing that seems to add additional data points for the adenoma component, not just the malignant component. And I think of all of those non-invasive tests as additive, right? Heme, and then FIT DNA, and every time it's just a slight refinement. And so I think colonoscopy still allows us to get the best gauge, number one. Number two, allows us to have that early removal of polyps, which we know decreases cancer.
So the therapeutic aspect. And I want to get back to that again, because I know you're trained as a therapeutic endoscopist as well as a general gastroenterologist. And we've certainly made enormous advances in our ability to remove large polyps, complex polyps at the time of colonoscopy, and probably have saved people from a lot of surgeries.
Yes.
Not that the surgeons are too happy about that at the time. But so where are we in your practice? I know you take on a lot of these polyps. Where are you with what you will do in terms of endoscopic submucosal resection or endoscopic mucosal resection? Where are we in terms of our ability to deal with large polyps or difficult polyps?
So I think we've had an amazing ability to have high resolution imaging that allows us to get a really good sense of where the polyp is, as well as with techniques like EMR, where we're injecting it under the polyp to be able to get a really safe margin. And it's funny that you bring up the colorectal surgeons, because they're doing ESDs as well now. So they're driving colonoscopes to do dissections because they realize leaving native orifice or not having to introduce a cut to a patient, it's always superior for the patient as well. So, but I do think the techniques have improved, and it's interesting because I've been in practice long enough that I've actually had a change in the way that I approach things. We're so good now at EMR that I used to stop and have the patient come back, talk to them about, hey, look, there's this EMR that needs to be done. And then we go and reschedule it. But now I just take it off because we can take it off safely. We can put clips over it. The patients do amazingly afterwards. And with CO2 and some of the other things that we have, they actually tolerate the procedure extremely well.
Now, one of the things we've introduced at Houston Methodist across the entire Houston Methodist system over the past couple of years is open access. So, Dr. Schiesser, how has that been working for you?
I think open access provides a really amazing opportunity for patients because they don't have to make a whole other visit. They can just go online. They usually have a primary care doctor within Methodist they've sort of already talked to about this, and then they can just get set up for their colonoscopy. So clinic space is always difficult. It takes a little while to get into our clinics, unfortunately, but this offers a whole separate pathway where they can just kind of fast track to getting their colonoscopy. So,
and I would assume that in the not too distant future, we can use AI and other methods to even better refine who goes straight to colonoscopy and who should perhaps have a visit or have some other evaluation. Dr. Singh, you see these patients when we've made the diagnosis and we've assessed them. How comfortable are you as a holistic cancer doctor in terms of the removal of early stage cancers endoscopically versus surgery, etc.?
Yeah, that's a great question. I mean, there's some degree of anxiety, from our side when there is just an endoscopic mucosal resection of a malignant tumor, because we do worry a little bit about what's going on in the lymph nodes. Because we have, experience-wise, we've seen patients who, they look stage 1, everything looks okay, and then they go for the surgery, and there it is in the lymph nodes when the resection occurs. But I think in those situations, we just have to kind of monitor closely the patient. We have very good imaging. We have very good, radiology support here. So I think, especially with rectal protocol, MRI, we can be more confident that it's not in the lymph nodes. That's always kind of our concern. And then, we just monitor closely. And then if anything does occur, then of course we, escalate the amount of interventions we need to do.
Because with modern endoscopic techniques, you can get really a whole specimen, and you can really evaluate the specimen.
Specimen itself isn't the concern or the technique. The question is still a little bit, what's in that? What's beyond that wall there?
Right.
Is it in the lymph nodes or not?
But that risk is still quite low.
It is going to be low for an early stage one. Yeah. Mm-hmm.
So I wanted you to take up another topic, which is a new one, and this is liquid biopsy and the ability to detect tumor in blood.
Mm-hmm.
Where are we with that whole situation in relation to colon cancer?
So I think probably just talking about like Signatera, for example,
Yes.
where we're looking at circulating tumor cell DNA.
Correct. Yeah.
So Signatera, now there's different techniques and modalities, but Signatera specifically, you do need to have an adequate amount of tissue to analyze what the cancer DNA basically looks like in that individual. And then of course you're sending the blood off. So colorectal is where we use it the most, to be honest, especially in stage 2 patients when we're trying to make a decision. So as we all know, stage 1 has an excellent prognosis. They don't require, our input or any adjuvant chemotherapy. Stage 3, we'll put that to the side right now. But right now, of course, they are requiring adjuvant chemotherapy. That is standard of care. Stage 2 is always sort of that black box, who's going to need it, who's not going to need it. And that's where Signatera is very helpful. So we know 80% are going to be cured by the surgeons, but there's this 20%, which is not an insignificant number, that is going to potentially recur and would need adjuvant chemo. So the big question is, who's that 20%?
Right.
So in the past, it was always clinical pathologic, features. We'd look at LVI, obstruction, perforation, et cetera. But now we can use Signatera, and we know that we have good data that if the patient is Signatera 0 for stage 2, the probability of recurrence is very, very
Would you just take us through exactly what's involved with Signatera in
Sure.
terms of the evaluation and the scoring?
Yes. So basically, it's the tissue is out. It can be simply actually from a biopsy that is done by colonoscopy. Most of the time that works. Sometimes the amount of tissue taken out by colonoscopy, that the test will fail. Definitely we can do it after the surgery. We kind of prefer, if possible, to do it off of the colonoscopy specimen. So you guys send it to Path. It sits in Path. We see the patient. Hopefully we can see the patient before surgery. We do like that as medical oncologists. Then we simply draw their blood. The blood is sent to the company, Signatera, and then Signatera will request the tissue, and it doesn't have to be fresh tissue. It's the one in the paraffin blocks. That will be sent to Signatera. They will analyze the tissue for looking what the DNA signature is, and then they've got the blood there, and they're going to look for it in the blood. That's simply what it is. And so it's going to come back. What we want to see is obviously 0, but it's a scale, it's a spectrum. And so they'll report out how much, per deciliter of DNA that they're seeing. So if you know before surgery that it's already positive, that's actually quite helpful, because then after surgery, especially for stage 2, we want to see it as a 0, right? You do have to be a little bit careful when you draw the Signatera after surgery. You don't want to draw it right after the manipulation, because you could have a false elevation, false positive. So we usually wait about a month or so before we draw it. And then if it's 0, then we feel very confident that it's very low probability that patient's going to recur. Now, on the flip side, if you see a stage 2 patient who is Signatera positive, after surgery, that is going to be a patient we're going to offer adjuvant chemotherapy to.
So that has represented a significant advance in terms of selecting stage 2 patients for adjuvant chemotherapy.
Several patients from having to undergo chemotherapy.
On the other side, you've actually been able to target your chemotherapy more appropriately
Exactly.
to those who really need it.
Yeah, and now the next phase is moving it into the stage 3 patients, because we also know we're probably over-treating. Not every stage 3A patient requires adjuvant chemotherapy. Right now, I just want to be clear that current standard is yes, we do. But trying to also figure out those who don't need it, and then also trying to reduce the number of months as well, 3 versus 6 months.
So in Dr. Desai and Dr. Schiesser, in your clinical practice, has this become routine to get these testing done?
So I will say I just default to sending the patients to oncology at the time of diagnosis, but I did want to ask one question, but I would say we usually lead it to oncology first, but I wonder, will it change, Rachel, how we take biopsies?
That's what I was
We're taking
thinking.
biopsies of tumors and they just start bleeding immediately. So we start to get a little panic because we can't fix that tumor bleeding in reality. But if we think it's going to need something like that advanced testing and that can be done before surgical resection, then I think it makes a ton of sense for us to be a little bit more aggressive. My level of concern that the bleeding is going to be significant is maybe less, but I think it may change the way that I advise even my other gastroenterology colleagues, like, hey, look, they may need this testing, a little bit more tissue for sampling purposes, probably beneficial, right?
Absolutely. That's what I was thinking. If there was some guidance as to, how many standard forceps would be required for the testing to help us.
It would be
maybe take more than just for the diagnosis.
Yeah, because we can usually get the diagnosis, frankly, like endoscopically, like, oh, that's bad. We probably need to get that cut out. But realistically, there's a wide variance, I would imagine, in how much sample we actually take.
So just to get back to something you mentioned earlier in your introductory remarks, Dr. Singh, you mentioned about genetic testing.
Right.
And you mentioned your disappointment in not picking up germline mutations in these younger patients.
Right.
Are there any new promising genetic tests on the horizon that might help us to identify these patients? I know we can identify Lynch, we can develop the other syndromes, but they're a relatively small proportion of patients with colon cancer. And I think you used the term sporadic colon cancer.
Right.
So in these individuals, is there anything on the horizon that might help us to identify these before they even develop cancer?
Yeah, that's a good question. I mean, I don't think we're going to pick that up by genetics because unfortunately it doesn't look to be genetically driven. It's coming back negative. And the panels we send, we don't just send, it used to be in the past, we would select, one gene, we're looking for Lynch or we're looking for BRCA. Now, most of the time, most oncologists are sending panel testing. So we're already looking at 70 genes, we're looking at ATM, BRCA, Lynch, everything. And they are coming back negative. I don't think there's much of a change germline-wise, really, to be honest. Major question is why it's happening. And then one question I have for you guys, because you do some of the non-invasive, Cologuard, are there trials going on right now? Because that would be the question, right, is can we start doing Cologuard in patients who are 20s and 30s as part of their just general screening to try to pick up? Because the cost of that is not so high compared to a colonoscopy.
No, I'm sure there are. The other area, and actually Dr. Desai mentioned this, is microbiome. There have been a number of studies, some of which were done by former colleagues of mine, which show that the oral microbiome was actually quite predictive of polyps and cancer. Now, I know that there are large-scale studies going on looking at that. I haven't seen the results yet, but that could be a very simple test. If the oral microbiome is truly predictive of even polyps, that could make life very easy. And then you could really hone in your colonoscopy on a more select group of patients. From your point of view, Dr. Schiesser, what else are you looking for to try and help you identify patients better or manage patients better, looking to the future?
Well, ideally, we would make some progress in the non-invasive tests. We as you were discussing blood tests, I was thinking about, we do now have 2 FDA-approved blood tests. They do have a lower sensitivity for detecting colon cancer and especially precancerous polyps, but it's a blood test. You get all your routine labs. It's very easy to do. I would probably only recommend that for people who are of average risk and who just weren't going to do a stool test or a colonoscopy. And also the important thing to talk about there too is people shouldn't be getting that unless they are due for colon cancer screening, and if they'll follow up with a colonoscopy. But otherwise, aside from symptoms, age, family history, there's not a lot of else to go on.
So there's one other topic I want to bring up, and I'm a little bit nervous bringing this up because it may cause a little bit of anxiety among certain people, and that's the recent reports of colon cancer in young people who are extreme exercise fanatics. These are ultra marathoners who are developing colon cancer. We don't know what the reason for it is. There are various hypotheses out there. Have you encountered this, Dr. Singh, in your practice?
Yeah, it's interesting you said that. I just saw kind of an ultra fit marathon person, although it was a different malignancy, it was ovarian. But I've also seen a couple of marathon runners, people who are ultra fit, getting malignancy, GI malignancy. I just felt like it was a random event, but so I'm interested to hear what
it was more in the kind of the quasi-medical press, if you like, but there was a piece in the New York Times a few weeks ago about this, and a number of eminent colleagues of ours commented on this. Like, people wonder, they can get this ischemia in the colon, whether that's occurring on a recurrent basis. Some people discounted that, whether it could be microbiome related again, or dietary related. But it appears to be a phenomenon. A series was written up really quite recently, but it could account for maybe a very small number of these younger patients getting. Of course, I was delighted to hear about this because I'd never done a 5K.
Colon cancer preventative. Sitting on the couch.
Studiously adhering to that regime. That's right. I want to get back to the global issue because, Houston is one of the most diverse cities in the US, perhaps the most diverse, and we have populations from all over the world who are at risk for a variety of cancers. And as I mentioned, we're seeing increasing rates of colon cancer. And this is going to be a global problem, because some of these countries don't have the wherewithal or the finances to do colon cancer screening. Do you have any thoughts as to how they might approach this emerging problem for their populations?
Yeah, that's a good question. So I think there may be a situation where these non-invasive testing is going to have to probably be utilized more, even though the sensitivity and specificity is not as high as colonoscopy, just simply because of ease, right?
It's better than nothing.
Yeah, exactly. And I was kind of interested in, Dr. Schiesser's comment about the blood. It is interesting how some people, even though we think of Cologuard as easy, they will also balk simply at that. And so it's actually a good point if there could be more sensitive blood tests, and that could also help, increase the chance of catching these things early.
Yeah, because even in our resource-rich environment, some 30% of people who are eligible for screening are just not getting it done for whatever reason.
Yeah, it's even worse in Texas. Like, it's 59% of eligible patients that actually get screened, and on our young cohort of patients, it's 40%, and that's the people that are eligible, right? So that's 45 to 54, that cohort, because they've done the data analysis of that in Texas, where we have some of the biggest medical facilities and centers in the whole country. We still only screen about 40% of our patients. So we're still not perfect. And I agree. Like, the idea, all gastroenterologists like the idea that colonoscopy is the best. We need to be doing as many of them and as frequently as possible. But there is that bridge of, oh, look, if we're only going to get, even in our open access capacity, which we're doing a great job, we're above national norms. We actually get in open access about 35% of our patients in to do an open access colonoscopy, which is better than the big studies.
It sounds terrible, but actually is.
It's amazing. Actually, when you look at countries that had open access and they did it for a whole population, 19 to 20%. So it's great. And we get those patients in at a rate that's higher than all of the previous studies, but still there's a lot of fruit left on the tree in terms of our ability to be able to get higher screening. And I've always told patients, look, if you don't want to have a colonoscopy, at least let me screen you some way.
Yes.
Because if I can screen you some way, then at least we can be reassured.
Yeah.
It is a little tricky, though, with a patient who, my buy-in statement to them is, if we're going to do a Cologuard or we're going to do a Septin 9, if the test is positive, then you understand you got to come for a colonoscopy, because I want to make sure that we have that conversation in advance, that not sitting on these results, if they're positive, that is worse in my mind than head in the ground, because you do want to make sure you've at least had that conversation. And I think that's to me, Dr. Quigley, where that open access portal needs to really evolve, which is, okay, look, if they don't want to come for a colonoscopy and they're agreeing to a screening tool that is non-invasive, that they understand and have the education piece behind to say, okay, well, if the test does come back positive, we need to act on those results.
Right.
So I have a very difficult question for the three of you before we finish. And that is, what do you do with the patient who has a positive Cologuard and a negative colonoscopy? Now, of course, you might have missed something, but this has happened to me. So, you've gone very carefully, you've examined everything carefully, gone back and looked again at the sequence, you've done all these things. You can't find anything.
Yeah. What
do you do next?
Yeah, I've had it happen on more than one occasion. It's often those patients are meeting me first, so I talk about the 90% accuracy. So I use that to my favor when I come back if the colonoscopy is negative. But if they've had that good, high quality examination, at least all our guidelines currently tell us we don't have to do anything more than just the normal routine screening. I will admit, it makes me paranoid.
I agree. At that point,
that's the way I approach it.
I provide reassurance.
Yeah.
The reason I bring it up is that many years ago, I heard David Alquist, who just invented Cologuard, giving a talk about this, and he mentioned its potential to pick up other cancers, be it pancreatic cancer or small bowel cancer, even gastric cancer, which then, of course, brings the nightmare scenario. Should you then go and do an upper endoscopy? Should you do an endoscopic ultrasound? Should you do all these things? What's your opinion, Dr. Singh?
Yeah, I mean, it does make you anxious, because I've seen also a couple of times that, hey, Cologuard is positive, and I point that out to the patient. Hey, do you know that this is positive? And they said, yeah, but my GI doctor said since my colonoscopy was okay, that it's not a problem. So, I guess that, question would be, what do you guys do? Do you repeat it? Do you do a colonoscopy earlier, or do you just simply, do you feel comfortable to say 10 years for your next colonoscopy when the Cologuard is positive?
Yeah, if I'm acting on the Cologuard, I will admit maybe it's my own intrinsic arrogance. Like if they did a good prep and we spent our appropriate amount of time, then we've done what I still consider the gold standard evaluation for colon cancer.
I think you've got to trust yourself in that situation.
So you don't do upper endoscopy, do a CT?
I don't. And I have a hard time defending it. Like we can talk about it as this place where we get to do everything for free, but it's not going to be. And patients have to take on a huge medical cost if we're just going to start now doing random screenings. And so it's really hard. I do think that we kind of keep a close eye. So I will follow those patients serially and say, hey, look, let's just check in together, make sure we're doing the other appropriate screening things if they haven't been done already. But I don't go down the rabbit hole.
Is there any study looking at that, you think?
The only kind of case series, nothing really. But I think it's very important to add that we're talking here about somebody who's asymptomatic, is having routine colon cancer screening, has no anemia, no other features that you'd worry about. I think if any of those things come into play, there's a completely different conversation.
Absolutely.
I do wish when we would get a positive result, we could be told, is it the fit portion of it, which could have been hemorrhoids or AVMs or something, or, is it the DNA portion of it? We don't know.
Yes.
So
that's a very good point, actually. So I want to give you a few minutes, Dr. Singh, to talk about where we are with chemotherapy. There's been a lot of advances in chemotherapy over the last few years. How have they impacted on the management of people with stage 3, stage 4 colon cancer?
Yeah, I guess from my perspective, chemotherapy advances have kind of a little bit slowed down. So the standard adjuvant chemotherapy is still pretty similar to how it was before. So we still have the same backbone of 5-fluorouracil that we've had for 60 plus years. Of course, adding second drug, oxaliplatinum, that has become standard now in the adjuvant setting. You do have to be a little bit careful. Oxaliplatinum can have some significant neuropathy issues that can become permanent. And the benefit of that addition of oxaliplatinum is not so huge. So one has to be very careful we don't leave anybody with a permanent issue after adjuvant chemotherapy. So adjuvant has been pretty steady now for many years, 5-fluorouracil based, either IV or the oral form is Xeloda with oxaliplatinum. Now for metastatic disease, first line treatment, the main thing, most important is are they mismatch repair deficient? That's got to be your main thing that you look at. Because if they are mismatch repair deficient, they can have just a home run response, even if they have metastatic disease, to immunotherapy. I think that's been the sort of the blockbuster change.
That's been the big breakthrough.
That's been the great breakthrough in that percentage of patients.
Yes.
Question is how to make the rest of them, respond to immunotherapy. And there's obviously lots of trials going on looking at that. Now, if you're mismatch repair proficient, and if you're metastatic, there's sort of an algorithm that we go through. Now, if a patient has a very high, heavy disease burden, we will combine 3 cytotoxic chemotherapy drugs and give a targeted agent, which depends, of course, also on their KRAS status. And then we cycle through. I mean, definitely there's been improvement. I mean, we've gone, 20-something years ago was a 1-year overall survival for metastatic colorectal patients to now slightly over 2 years now, but still obviously a lot of room to go. There's definitely been more advances in terms of the 3rd, 4th, 5th line treatments. Fruquintinib, a multi-tyrosine kinase inhibitor, Nexavar, sorafenib, also Lonsurf. But there's still, the time interval that you get to control this disease starts to become shorter and shorter with each line of treatment, and the response rates go down. So there's still kind of a long way to go after you've had that first, 5-FU oxaliplatinum, 5-FU irinotecan, adding Avastin, cetuximab. After that, it's sort of you kind of fall off the cliff a little bit, and we need a little bit better therapeutics. So also referring for clinical trials to try to find new therapeutics is important for all of us.
And something for a conversation another day is the whole issue, of course, of resection of isolated liver metastases, etc.
Yes, so that is a very important point, is obviously looking at what is the pattern of metastasis. So somebody who has lung, bone, liver is totally different from somebody who has liver-only metastasis. So that's a very good point. So patients who do have liver-only metastasis, we do, of course, start with systemic treatment. We just sort of a test biology-wise that they're favorable, they are going to respond to systemic treatment, they're not going to break through and metastasize to other sites. And then if they have liver-only limited disease and they do respond, then of course we start looking at, if their primary has not been removed, remove the primary, and then working with our liver surgeons to see about metastectomy removing. And then of course, here at Methodist, we do have access to a very large and robust liver transplant program. So that's very strict criteria. But if you've had multiple lesions, which are not going to be amendable to a combination of locally ablative treatments plus metastectomy, then evaluating in a multidisciplinary fashion for liver transplant for those folks is also very important.
Terrific. Look, we've had a wonderful conversation. We've covered everything from advances in diagnosis to new genetic testing to colonoscopy is king, and of course, discussing new advances in chemotherapy for patients who need adjuvant chemotherapy. I'd like to thank my panelists who've been extremely generous with their time and their knowledge. I think it's been a great discussion, and I hope we've given you some new ideas to take back to your clinical practice. So I would like to thank you for being with us today, and we look forward to hearing your questions if you have any for us. Thank you very much.